Good morning. My name is Tom Stelfox. As Scientific Director of the O'Brien Institute for Public Health, it gives me tremendous pleasure to welcome you to today's town hall, Anatomy of a Pandemic, Hopes and Challenges for the Coronavirus Vaccine. This event is jointly brought to you by the O'Brien Institute for Public Health and the 19 to 0 initiative. The O'Brien Institute is a research institute at the University of Calgary with over 500 members. We function at the interface of the university and society, and our mission is to conduct research that impacts public health. The 19 to 0 initiative is a University of Calgary-grown coalition that represents academics, public health experts, behavioral economists, and creative professionals from around the world working to optimize the public health response to the COVID-19 pandemic. It's been almost a year since the WHO declared COVID-19 to be a pandemic. It still continues to have a major impact on our world. People still become sick. Children continue to struggle to get educations, adults fight for their livelihoods, and we all strain against the pandemic's psychological impact. Recently, the prospect of vaccination has emerged. With this comes both hopes and challenges. I can tell you from a personal perspective that as an ICU physician, I've already been vaccinated. This is an incredible privilege when most people are still waiting for this opportunity. How do we extend COVID-19 vaccination to the world's population? Today, we bring you an expert panel to discuss these hopes and challenges. What do we know about the vaccines available? What challenges do we face? How do we collectively engage in a successful vaccination campaign? As a global community, we have successfully done this in the past with polio and smallpox. How do we do it for COVID-19? To lead us in today's discussion, we are fortunate to have Dr. Shannon McDonald, Professor of Nursing at the University of Alberta. Dr. McDonald is a pediatric nurse. She's an expert in the safety and public uptake of vaccinations. She advises policymakers on how to address real-world immunization challenges. Dr. McDonald, thank you for leading us in today's discussion.
Good morning. Thank you for having me. I'd like to welcome everybody to this really exciting panel discussion we have ahead of us, hosted by the University of Calgary O'Brien Institute of Public Health and 19 to 0. I'd also like to take this opportunity to acknowledge the traditional territories of the people of Treaty 7 in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta Region 3. And personally, I'm joining you from the Edmonton area, which is located on the ancestral lands of First Nations and Métis people in what is now Treaty 6 territory in Métis Region 4. And I truly remain mindful that I am a visitor to this land that was inhabited by others long before my family arrived here. We're fortunate today to bring together a panel of experts from across the continent to discuss the exciting developments and significant challenges associated with the distribution, delivery, and acceptance of the new COVID-19 vaccines. The first speaker today will be Dr. Jim Kellner, who is a clinician and primary researcher at Alberta Children's Hospital, a full professor in the Department of Pediatrics, Community Health Sciences, and Microbiology, Immunology, and Infectious Diseases at the University of Calgary. The second speaker today will be Dr. Jia Hu. Dr. Hu is a family physician and medical officer of health with Alberta Health Services and the chair of 19 to 0. He's also a corporate medical director with the Canadian Pension Plan Investment Board with Cleveland Clinic, Canada. Our third speaker today is Dr. Gina Parsons-Lee. Dr. Parsons-Lee is a medical sociologist and assistant professor in the School of Health Administration at Dalhousie University. She's currently leading a CIHR-funded program of research to document levels of public awareness and understanding of COVID-19 in Canada, with the ultimate goal to educate, engage, and empower Canadians toward improved health literacy. And our fourth speaker will be Dr. Raj Pannu, who is the co-founder and CEO of Emergence Creative, a New York-based social impact communications agency. He's also the co-founder of 19 to 0. So we have a great panel with really diverse perspectives on the topic we're speaking of today. Just as a reminder, the event will be recorded and will be shared with attendees on the Anatomy of a Pandemic landing page. Each speaker will speak for approximately 7 minutes, and then we'll save the question and answer period after all 4 presenters have spoken. So throughout and following the presentations, feel free to ask questions by typing them into the Q&A box, or if you're following us on other social media, enter your comments there and they will all be funneled through to us. And they'll all be addressed after all the speakers present. If you're a tweeter, the Twitter hashtag is listed on the screen there. And I think we are ready to go with our very first speaker. So I will invite Dr. Jim Kellner to the virtual stage.
Well, good morning, everyone, and thanks very much, Dr. McDonald. And I'm going to speak briefly about COVID-19 vaccine development, efficacy, and safety at the beginning of this panel. So first, to talk about vaccine development, and a question that lots of people have, where the vaccines develop too quickly. So first couple of slides, this outlines what the normal course of events is in the development of vaccines worldwide. People have heard, the process takes a long time. And the typical time for vaccine development in the laboratory and all phases of human testing is about 10 to 15 years. It's important to note, though, that within those 10 to 15 years, there are large periods of time where there's no active work going on regarding the vaccine development. Some work is done, there's a pause, people reflect on it, write it up, think about the next steps and move forward. And it takes there are lots of pauses and gaps in that time. Then in a sequential way, only after all the vaccine development is completed, there's in Western countries and in Canada, regulatory review and approval at a national level through Health Canada. Recommendations for use of the vaccine are made through the Public Health Agency of Canada and its committees, most notably the National Advisory Committee on Immunization, or NACI, which I'll speak to later as well. And this takes months to years. And then after that, it moves to the provinces and territories where scheduling is arranged, safety standards and measurement are considered, and procurement of vaccine is normally done at the provincial or territorial level. And then the vaccine is provided by public health or system or practitioners. This takes months to years to get going. And only after all that do you have disease effectively and safely prevented. COVID has really disrupted this whole approach, and with the global release of the genome of SARS-CoV-2 in early January last year, the whole process of developing vaccines based on existing science and all phases of human testing was something called adaptive clinical trial designs, took less than a year. At the same time, concurrently, national governments like Canada made advanced purchase agreements to buy millions of doses of vaccines, and this supported the production of vaccines even before you'd know if they were working. The companies have been producing vaccines. Then the process of rolling submission for federal approval. This is where the companies provide information as it becomes available, and it's considered as it becomes available rather than waiting for it all at once. NACI made some preliminary guidance statements on prioritizing populations, and those were just updated yesterday. And so all this took place over months, and it was happening at the same time as vaccine development. Then the concurrent effort at the provinces and territories to do scheduling, set safety standards, that took weeks to months, and again was happening concurrently. And so we got to the point where in December of 2020, vaccines started to be used in Canada. And I would characterize this process as rapid, but not rushed. So is anything missing when you develop vaccines so quickly? And three aspects to comment on. First, safety. And I think you can confidently say that nothing is missing. The duration of follow-up in the clinical trials that for vaccines that have been approved so far has been typical with any vaccine development. A 2-month follow-up after provision of the vaccine is sufficient because it's known that it's exceedingly unlikely that any adverse events that could occur will occur more than 6 weeks after vaccine administration. What may happen, and I'll talk about anaphylaxis in a bit, is that the frequency of events, what we see is may increase or decrease over time, and we can see how that's evolved with anaphylaxis. But the safety evaluation part, which is the #1 outcome to look at, is sufficient even with very rapidly developed vaccines. For efficacy, we know that, and we'll talk mostly about the 2 mRNA vaccines, the Moderna and Pfizer vaccines. We know that amazing efficacy, over 90% found with these vaccines. And so what we don't know with a more rapid process is what the longer term duration for months to years it will be for protection. But when you saw more than 90% efficacy in the short term in the middle of a raging pandemic, there was no obvious approach but to look at providing at least interim approval of these vaccines. And then as well, populations, and we'll speak briefly about that, but not all populations could be studied in the short time. And in particular, children, pregnant, breastfeeding women, and persons with various kinds of immunocompromising disorders have not been studied at all or nor fully studied. And that's to come in the time to come. So a lot of vaccines under development. This is an update from the New York Times, which is updated weekly. There's over almost 200 vaccines under some state of development worldwide. 69 vaccines in human clinical trials at this time. And so an ever increasing number that have been authorized for use in one country or another. I'm going to go to the list for Canada. And the Canadian government, with advice from the Vaccine Advisory Committee, chose 7 vaccines to make advanced purchase agreements with. And everybody knows about Pfizer and Moderna, bolded at the top there, with 95% and 94% efficacy. This remarkably high efficacy for 2 similar vaccines, mRNA vaccines, led to the approval of these vaccines and starting to use them in December. The news, just sort of to remind people about for now, is that there are several other vaccines in the wings that we may see approved for use in Canada before very long. The AstraZeneca vaccine, which is also now going to be produced, the same vaccine, not just by AstraZeneca, but by a large pharmaceutical company in India. And this is a different vaccine, a viral vector vaccine, and it is approved for use in the UK. Its efficacy is not as high, and there's been some somewhat confusing results, but overall about 65% efficacy, and highest in the UK compared to other countries, and notably higher efficacy if the second dose is given a longer time out. People have heard about that. The 2 you may have paid less attention to are the Janssen or Johnson & Johnson viral vector vaccine, which has had press release data so far only, showing 66% overall efficacy to prevent moderate to severe disease. And the Novavax vaccine, which is a 2-dose, different kind of vaccine, recombinant spike vaccine, sort of like hepatitis B vaccine. There, by press release again, 89% efficacy. And these last 2 vaccines have shown greater or lesser degree of efficacy against variants in the UK and South Africa. All of these 5 vaccines have been submitted for approval in Canada, the Novavax most recently. So there's likely to be several more vaccines available in Canada within the coming weeks to months. So I'm not going to dwell on this slide, but just to say when it comes to vaccine safety and adverse effects, there's a very standardized approach within clinical trials, as well as after vaccines have been implemented to do measurement of and surveillance for vaccine safety. And I won't go through all the terminology, but just to, and we can talk about this more later, but to show the point that there's organized approach to this. I'll talk about two specific situations before I finish. The first, when it comes to safety, is about the issue of anaphylaxis, because this came up soon after implementation of the vaccines, and there's a little bit of a signal of this during the vaccine clinical trials. So what's evolved is that initially, when the Pfizer vaccine came out, there was an estimate made that the rate of an anaphylactic reaction occurring after delivery of the vaccine was about 10 to 11 cases of anaphylaxis per million doses delivered. But now, just over the end of last week, there's been updated data that's come from the US Centers for Disease Control after 17.5 million doses of vaccine, either the Pfizer or Moderna vaccines have been given. And so now we have more refined estimates of the rate of anaphylaxis, 4.7 cases per million doses for Pfizer and 2.5 cases per million doses for Moderna. So important adverse effect, absolutely, but is rare. This is number of cases per million doses delivered. And this is, just to jump to the bottom for a second, this is well within the, what we see with other vaccines for which anaphylaxis can occur, where the rate of anaphylaxis is 1 to 10 per million doses delivered. So the NACI statement from January, as others thinking about it are speculating that possibly the polyethylene glycols, or PEGs, that are within the vaccines as part of the delivery vehicle may be the main allergen of concern, but there's no data for sure on this. There is an approach to this, as with all new vaccines, is the expectation is that nobody should get the vaccine if they have a contraindication to a known component of the vaccine. And the approach to it, especially in people with a known history of allergies, is to observe for longer after they've had the vaccine, more than the usual observation. And I'll just finally talk about COVID-19 and pregnancy and breastfeeding, because this is one where, unlike children, where really no children are getting the vaccine, there's been a lot of work to say, is it reasonable to look at giving the vaccine to pregnant women at this time? And so NACI, like other organizations, suggests that the vaccine may be offered to pregnant or breastfeeding individuals if a risk assessment deems that the benefits outweigh the potential risk for that individual and the fetus or infant, and if informed consent is provided. The considerations around this, the evidence is evolving. There's no published data from clinical trials yet. There's limited data from animal development and reproductive studies that you would normally want to see before using a vaccine in pregnant women. There is, however, emerging data from vaccination in pregnant women. Over 10,000 pregnant women in the US have received the vaccine, and it's been recorded. There's been no increase in miscarriage, preterm delivery, or stillbirths versus the usual population rates. And then the consideration, of course, that pregnant or breastfeeding women may have increased risk of exposure depending on what their work is. I'm sorry. They may have increased risk of exposure depending on what their work is, and they may have increased risk of severe disease, especially pregnant women. And then, of course, it's important to remember the usual avoidance of COVID-19 considerations. So in conclusion, the development of COVID-19 vaccines has been rapid but not rushed. The implementation of safe, highly effective vaccines after less than a year is, in my view, astonishing. More clinical trials followed by longer-term study and monitoring of vaccines will provide more complete understanding of the impact of vaccines. So with that, I will stop sharing and pass the screen to my colleague, Dr. Jia Hu.
Great. Let me just load up my slides. Happy Tuesday, everybody. Ooh. Can you guys see this?
Yes, we can see the slides.
Okay, perfect. Thanks for the presentation, Jim. He's very good at vaccine science. He's my boss in many respects. Anyways, so as Liz introduced, so I'm one of the medical officers of health with Alberta Health Services, but I also chair this national group called 19 to 0. And sort of in that role, I work with Raj and others on really building vaccine confidence and COVID behavior change, actually in Canada, the US, and the world. I guess in my various other jobs, I'm probably involved in every aspect of vaccine except for actual federal procurement. And so I'll actually talk a bit about supply, because I think that's actually very top of mind for everybody as per the news. But first of all, I'll just, what is 19 to 0? We're basically a coalition of 400, 500, who knows, lots of people, across multiple sectors, healthcare, academia, civil society, private sector, government, really aimed at COVID-19 behavior change and vaccine uptake. And I think all of this has sort of been created over the last like 6 months. And I think that sort of speaks to, like gap, need sort of for this work to be done. I won't go through this too much, but it's sort of been like we work across a number of domains. We call it a multimodal omni-channel approach to behavior change. Lots of data, and very heavily on the intervention side, I think, which I think is quite critical. Now, I'll quickly actually just talk a bit about sort of the vaccine confidence issue. And I think that one thing to keep in mind is that I do think with supply sort of being so constrained right now, what sort of filled the discourse is supply issues. There's been delays with Moderna, with Pfizer, but there will come a time, and that time will come a bit later in Canada than some other countries, as I'll discuss, where we will have an abundance of vaccine. And we really will have to sort of work on the confidence issue, right? And so, essentially, we work a lot with Angus Reid, and there's lots of groups that actually collect national data on vaccine uptake. And the way, like how many Canadians want the vaccine? So the way Angus Reid asked the question are, would you get a vaccine as soon as available? Would you get a vaccine, but maybe later? Would not sure, and no. And so if we look sort of how the uptake sort of has evolved over time across Canada, you can see that sort of early in the summer, 46% of Canadians willing to be vaccinated as soon as available. It dropped to 39% by the end of the summer. That sort of mirrored a decline that we saw in the United States as well, though it was probably a larger decline in the United States. And Trump actually probably had quite a lot to do with it. In November, whoopsie daisy, went down. This is like right after the Pfizer trials were press released, you had a slight uptick to 40%, December to 48%, and in January, this should say January, not December 20, we sort of reached our high watermark, which is 60% of Canadians saying that they would get vaccinated as soon as available. Now, I think that I sort of view this as almost like polling data. As in, one, it is quite susceptible to change and fluctuation. And two, across a number of polls, there broadly similarly some differences, right? So Leger, Ipsos, like a number of groups actually sort of collect this data. But I think that, what I would take from this at a very high level is a 60% uptake or willingness to take the vaccine as soon as available is pretty good. But, I don't think it's good enough. Like if you look at sort of some of the international comparison data, I think in China, it'd be like 90% or higher. And I think that, people talk a lot about this herd immunity thing. And more, I think we often cited 70% as a herd immunity threshold before, but, with the new variants that are more infectious, that may be slightly, less vaccines will be less effective, then your herd immunity goes up. Your herd immunity threshold is basically a function of how infectious the virus is and how effective the vaccine is. The second thing I would say is that it's kind of funny to me, but right now everybody's talking about supply, which they should talk about. And people are like, oh, we shouldn't really care too much about vaccine confidence. I don't think that's the right way of thinking about it, because we do have to prepare ahead of time, as in for let's say May, June, when Gen Pop vaccination will start, otherwise we won't be ready. And in fact, I would say the most common criticism, which is a sort of a fair one of public health, so people like me, is that we didn't prepare enough for all the stuff that we already seen happening. And I think that one of the biggest problems with sort of vaccine confidence and uptake is, I mean, like, writ large, these numbers, but it's not like public health government is particularly like good at this type of thing. I mean, you sort of see the campaigns people have, and so this is sort of why I think like an all society approach where you bring in sort of experts across the board is quite critical. This is some other sort of fun data which shows how much healthcare workers want vaccine, and I'll just highlight that the confidence is similar or lower to than the general public. So you see this blue line, it's non-healthcare worker, red line, healthcare worker. So this is a series of data collected by Stats Canada, organized by the Privy Council Office, or the impact, like the little like data shop that we work with a lot. And certainly I think this might have changed by January or December, as in healthcare workers would want it more, but it might not have actually. I mean, it's interesting because at least in December, we saw, PSWs or healthcare aides not wanting the vaccine a whole lot. By, last month, like a few weeks ago, read something in the Globe and Mail saying the estimate PSW uptake is 70%, although I don't know how Ontario would do that because they don't collect that data very well. But at the end of the day, for healthcare workers, right, like it's nice to have 70 or 80% uptake, but like if you're looking for 100% uptake in any group, it'd be this group to protect themselves and protect their patients. And I think that there's a lot that needs to be done. I mean, at the end of the day, like it's not like vaccines by themselves don't do anything. You need to put them into people's arms. And that never is going to be mandated by any government, at least in this country. And so we really gotta work on these numbers. So I think that, I mean, I don't go too deep in this, but when it comes to, there's many ways of sort of thinking about the uptake problem. But, I think trust is probably one of the most important underlying drivers of everything. This is like trust in government, trust in Health Canada, just trust in institutions, you might say. And so, I mean, I think we find that this is, I'm getting a little message. I'm probably going too long, maybe. But anyways, trust is important. How concerned people are is really important. Like, like people are much more likely to want to get the vaccine, or for that matter, follow public health rules if they worry about COVID. And then we got to sort of like optimize for like access and whatnot. The last thing I'll talk really briefly on is around the issue of vaccine supply. So, I mean, delays have been top of mind, and so this is sort of like these advanced purchase agreements Jim mentioned. Like these numbers roughly outline when we're supposed to get how much. So not a whole lot by the end of Q1, a bit more by the end of Q2, by the end of Q3, like quite a bit more. This is contingent on vaccines working. And Jim talked about the AstraZeneca vaccine, right? We're just going to have like a maybe 60, 70% efficacy, probably doesn't work that well in old people. And something like that actually also will probably hurt confidence because, I'd be like, should I take the AstraZeneca one or should I wait a few months or, a year to get the Moderna one, Pfizer one? And also the scale of manufacturing, right? So Pfizer delays, the Germany plant got an upgrade. But then, when that upgrade happened, the EU country supplies were maintained, but not to Canada because we are at an inherent disadvantage because we don't really have domestic manufacturing. We don't have companies. And so, I mean, happy to answer any questions on any of this stuff, but I will stop talking now and hand it over to the next speaker.
All right, thank you. Dr. Parsons-Lee, you are next.
Oh, I apologize. Can you hear me now?
Yes, we can hear you.
Yes. Thank you. Sorry about that.
That's all right.
Thank you for the opportunity to be part of the town hall. It's really an honor. Today I'll be speaking about COVID-19 information use and intentions to vaccinate in the Canadian public. It goes without saying that we're living in an unprecedented time. Never before have technology and social media been so rapidly used to keep the public informed, connected, and protected. Yet the speed and ease of information sharing has also led to increasing amounts of inaccurate or misleading information, known as misinformation, and calculated falsehoods, which are known as disinformation, being circulated about COVID-19. Knowing how to effectively get up-to-date and accurate information to the public is therefore crucial in supporting our public health response. To assist in tackling this issue, our research team conducted a national online survey of adult Canadians at the peak of the first wave of the pandemic to gain a better understanding of public beliefs, knowledge, and behaviors in response to COVID-19. Our sample of respondents was proportionally similar to the Canadian population in terms of sex, age distribution, marital status, education, and housing, but was more limited in terms of racial and ethnic origin, which unfortunately prevented our analysis by this demographic. The survey covered many topics, but today I'll focus on the questions we asked about information sources Canadians accessed and trusted to obtain information about COVID-19, as well as respondents' intentions to vaccinate. So what interesting things we learned about access, which are illustrated in the purple bars, and trust, which is illustrated in the green bars or the bluish green bars in information sources. Overall, we found that Canadian television news was the top information source accessed by the public for pandemic information, followed by digital government and public health sources, word of mouth conversations, and social media posts. Respondents tended to identify information coming from government and public health agencies as most trustworthy, yet they are not necessarily accessing this information directly from these agencies, which speaks to the need for a coordinated approach to science communication. We also analyzed patterns of information use by key demographics, including age, gender, education, and household income. Some of our most interesting findings were borne out in the differences that emerged across age groups. In fact, we found disproportionate responses between our oldest and youngest respondent groups, which were the 65 plus and the 18 to 29-year-olds, were relatively consistent across every one of our survey categories. In terms of trust in information sources, respondents aged 45 and older were 2 to 3 times more likely to seek and trust information from Canadian news sources than 18 to 29-year-olds, while younger adults were more likely to seek and trust information posted on social media, particularly social media produced by health organizations. When considering gender in our findings, we found that women were more likely to access and trust information from Canadian public health websites and the World Health Organization than men, and to report posts on social media from family and friends and acquaintances as less trustworthy than men. Meanwhile, men were more likely to access and trust American news sources than women, although it's worth noting that the percentages were pretty small, with just over 1/3 of men reporting that they access these sources. Finally, respondents with a university or college degree were more likely to access government and public health websites than were high school educated respondents. However, respondents with a high school education were just as likely to access Canadian news sources, and there were no significant differences by education in terms of sources felt to be most or least trustworthy. It's also worth noting that respondents with a high school education access fewer information sources on average than respondents in other education groups, which may indicate a smaller margin for error in getting the right information to this group. Shifting to vaccine intentions, 64% of respondents in our sample agreed or strongly agreed that they would get vaccinated for COVID-19, and only 8% disagreed or strongly disagreed. This shows that at the time of data collection, which was April and May of 2020, many Canadians were undecided about their intentions, which makes sense given that a vaccine had yet to be developed. Fast forward to more recent data collected by Ipsos in mid-January, and the number of Canadians who agree they'll get vaccinated as soon as possible is on the rise at 72%. However, 12% said they'll never get vaccinated, and another 15% said they'll opt to wait until 2022 or beyond, indicating that the margins of indecision are lessening for Canadians, which may make it more difficult to increase numbers overall. When we looked at intentions to vaccinate by demographic subgroup, we found striking differences. Younger adults, participants with less formal education, and those with lower household incomes were less likely to agree or strongly agree that they would get vaccinated, which mirrors the findings of other studies completed more recently. To dig deeper into these findings, we launched a series of follow-up interviews with survey participants. In our 18 to 29-year-old respondent group, 3 preliminary themes emerged regarding their lower intent to become vaccinated. The first was concerns around media portrayal of COVID-19 vaccines. 18 to 29-year-olds had strong beliefs that media outlets are fueling fear about vaccines for extra views and profits, which make them want to tune out coverage. The second was feeling removed or not thought of during the vaccine rollout. Participants had a strong sense of not being considered high risk or near the front of the line to receive a vaccine. And finally, participants identified a lack of accessible and accurate information about COVID-19 vaccines as impacting their sense of vaccine safety. Participants desire an online repository of accessible and verified information where they can educate themselves on the specific questions they have. To conclude, what we know about access and trust in COVID-19 information and sources can be used to improve vaccination uptake in Canada. From the findings I've shared with you today, we know that Canadians use a variety of sources to gain information. We need to be responsive to get accurate messaging through a variety of mediums. We also know that there are variations in the sources Canadians go to for information based on sociodemographic differences, with age-based differences being particularly striking. Finally, we know that at the time of this survey, Canadians reported high levels of trust in information disseminated by Canadian government and public health agencies. This is important because vaccine hesitancy is often associated with lack of trust in public institutions. However, trust is fragile and inconsistent messaging can quickly undermine the legitimacy of the source. It is clear that a one-source-fits-all approach to public health and science communication is inadequate. Attention to population-based demographics can help generate information relevant in format, tone, and medium to improve uptake and buy-in. This concludes my presentation for today. I'd like to quickly thank the entire research team and our network of knowledge users, with special thanks to Chloe DeGrood, Rebecca Brendan Mather, and Andrea Sue for their support of our survey work. I'd also like to thank Shelley Cooch and Shelley Longmore and Nadine Foster, who are members of the public and PIs on this grant, Dr. Kirsten Feist, who co-leads this research program, and Dr. Tom Stelfox for his mentorship of this work. Thank you very much.
Thank you very much, Dr. Parsons-Lee. And last but not least, we will have Dr. Raj Pannu.
Great. Can we start my video? Because it's just me. I don't have any slides. And I can't start it from my end. Start my video. Great. Perfect. Hi. Good morning, everyone. So I think we've had a really good sort of broad discussion this morning. Everything from, what is the nature of these vaccines? How safe are they? What is the supply of these vaccines? How available are they and will they be? And then what is the general perception of the Canadian population around these vaccines and whether they want to take it? And I think maybe I can go back and talk about, from my personal experience, what are the kinds of interventions that I think are required that will increase confidence of Canadians in vaccinations. So my personal background is that I'm an academic scientist. I'm a biochemist from Edmonton, although I live in New York City. And I moved to New York after my PhD in biochemistry about 20 years ago, and ended up getting a job in advertising, which is a sort of funny life transition. But it was an important one for me, and I think very relevant to this issue, because I became an executive at one of the largest advertising agencies in the world. And my job was to sort of create this sort of strategies around global dissemination of pharmaceutical products. So when they were made by companies, how do we create demand in populations to get people to want to take them? And I can tell you that that area of work is something that I'd never even known about until I came to New York. It's a very sort of specialized field. And it's a very both powerful and somewhat dangerous field to participate in. Powerful because advertising as a means of creating demand for anything, whether it's a laptop computer or whatever it is an extremely powerful, systematic, targeted, and intentional way of creating demand in a population. And why that's the reason why it's dangerous is that in the US in particular, it's a highly regulated industry, particularly around what companies can say to consumers, for example, around pharmaceutical products. And in many parts of the world, and largely true in Canada and other places, it's so powerful that it is in fact illegal. And companies are not allowed to promote products. That is entirely within the realm of the physicians. They can promote to the physicians, but they can't speak directly to the general population. And I think there's a very good reason for that, because it can lead to overprescription. It can lead to all kinds of different kinds of issues around public health. And so I think given that knowledge, I think that using an advertising approach to get people to be much more interested and engaged around particular issues is critical. So let me just go back to public health messaging in general. And this is not a criticism. This is just sort of a general perspective around public health communications. Public health communications in general tend to be very prescriptive, in the sense that they want people to do the right things for the right reasons. They want people to have a very strong general understanding of both the health and medical implications, for example, of the kind of medications they're taking. And in many cases, that is, I think, an unreasonable expectation. I think, very often the hurdles that are to overcome in terms of getting people to really understand the nuances, for example, of different kinds of medications and their implications are simply too complex. Having said that, there are ways to get people to do things, not in a sense to give them incorrect information, but to understand what their lived experience is, and to give them messages that exist within their ability to comprehend what those messages are. In kind of sort of crass advertising terms, that means it's getting the right message in front of the right people at the right time. And I think, it is that kind of perspective that I think we need in order to really solve this demand problem around vaccines. So just kind of in general, if you look at the hesitancy landscape, as we discussed before, there are people who have very reasonable concerns about vaccines. There are, danger, what are the safety issues? Is it too much too fast? Are they not well studied enough? How efficacious are they, around specific use cases? Jim talked about it earlier around, pregnancy or autoimmune disorders. Those are all very reasonable questions that are specifically to do with medications. Then there are other different groups, very often vulnerable populations, who may have certain, either religious biases, or they have had bad experiences with the healthcare system, or there are historical injustices, whether it's First Nations people or in the U.S. Black and Latin populations, where there's just a general and reasonable distrust of institutions. Also, there are access issues. In many parts, this is happening in the United States, here in New York, where there just aren't enough places for people to get vaccinated in very low-income communities. And then the third is this idea of misinformation, and that goes from everybody from people who are sort of the libertarian ilk, who think that their individual rights are being trampled upon, to adherence to very specific theories of sort of QAnon type global conspiracies, and then even just in general, and I think this is very prevalent among resistant populations, skepticism of different motivations of different interest groups. So the government wants to control us, for example. Pharmaceutical companies want to profit by doing this. Bill Gates is somehow trying to take over the world. And as a result, it's a very large constellation of reasons why people tend to be skeptical. And as a result, the key point about using a systematic targeted approach, whether it's through social media or paid media, is to be able to really understand and break down what are the both not just demographic, but psychographic issues around vaccine hesitancy, and then addressing them very, very specifically and in a very targeted manner. And so just to sum up, one of the key issues around 19 to 0 and what we're trying to do is that we are trying to take a sort of professional communications approach to the kind of demographic and psychographic data that we're getting from our polling, as well as social media scraping, as well as different kinds of focus grouping, and then using a creative approach, try to engage different groups with different worldviews and meet them where they are and try to persuade them in a very creative fashion towards accepting the vaccine. And so I'll stop there, but I do think that's kind of that is the sort of the basis of what we're doing. And it's kind of a thing that I've been evangelizing about in many different issues in global health for many years, which is, we have to kind of move towards to patient engagement, consumer engagement, general public engagement, if we're going to move the needle on many of these issues, particularly COVID, which is a huge issue right now. Thank you.
All right, well, thank you to all our speakers. I believe the plan is for everybody to turn their video on, the 4 speakers, and we'll proceed with the question and answer period. There's been a number of questions submitted already, and so we'll start with those. Just to mention, in the event that we're not able to get through all of the questions today, we'll be providing the presenters with any outstanding questions to answer following the event, and the responses will be provided to attendees on the Anatomy of a Pandemic landing page, which is also where you'll find the recorded video. So we've got some super questions already. I'll direct the questions to the speaker that I think it's probably most relevant to, but of course, any of the other speakers are welcome to jump in as well. So the first question is in relation to healthcare workers, and I suspect maybe Gina or Gia, maybe this is a good question for you. Have healthcare workers been polled per group? So I assume they mean by different types of healthcare workers. Are some less likely than others to want the vaccine? So we're wondering whether or not we have any data on that.
Yeah, I have some data. Let me just pull it up. Also, I think the host turned off my video. Are we supposed to turn our videos now? I have no idea. So, I mean, just a high level overview, right? So there's been one large survey of healthcare workers sort of done by the Public Health Agency of Canada. And sort of the way most of these surveys are done, right, is, and then our group did a pretty big one of Ontario healthcare workers focused on PSWs, which are healthcare aides. And then the Ontario College of Pharmacists and did like an N of 8,000 survey. So let me just pull up this little fact one. I think unlike sort of the other sort of sampling methodologies that we use, like the stuff that Gina and which is more like, what I'll call representative sampling. These are sort of like, we send these surveys out to whoever wants to answer them. But I think that I will just open this and others feel free to chime in as I find this little slide with the healthcare worker by type data. Okay, well, as I'll pull it up, I will just talk then if no one has anything to say. I mean, we do see sort of some differences, I think, for sure. I think some of the more pronounced groups that sort of have lower willingness to take vaccine are healthcare aides. But if you don't know what healthcare aides are basically sort of like the people who, get the least pay, like, the people like freeing $2 above minimum wage and spend most time with patients. Actually, they work primarily in long-term care and home care. They also often racialized, right? And so lots of healthcare aides, in Alberta, a lot of Filipino, South Asian, that in Ontario, same, plus Afro-Caribbean. And so I think, like when I think about there's sort of like the general public, if there is such a thing as the general public, but then, there's certain vulnerable populations, I think of like Black, ethnic, like racialized, Indigenous, like as the vulnerable population, and then you have healthcare aides, which are sort of like the intersection of healthcare workers and racialized vulnerable population. But I have found it now. So, oh Lord, we can take another question while I pull this up, Shannon. Sorry, all right. Otherwise, I'm just mumbling
Sure.
on. I'll show a slide.
Okay.
Like when
yeah, why don't we come back to that then? So this is an interesting question that relates perhaps to the racialized populations, or whichever language you prefer there. The question is, any thoughts on building trust amongst newcomer communities? We are nursing students working with immigrants and refugees in Calgary, and we are noticing quite a bit of vaccine hesitancy. Much of that hesitancy stemming from distrust of Canadian institutions and government. And maybe I'll read another question that's on a related topic, and then folks could weigh in. What work is being done to help groups like First Nations in Canada, who have a very legitimate concern regarding Canadian government motivations, who may have lower uptake of the vaccine? So I'm wondering, maybe Gina, if you're comfortable jumping in on that, either around newcomer populations or Indigenous populations. I think knowing your work, that might be something of relevance to you.
Your work is actually more relevant. I'm very lucky to be part of a grant that Shannon is leading that's directly in this area. So I think one of the things that's worth noting is that this is something that, is on the radar of public health. So FACT did put out a call for a grant call to look specifically at what they're calling equity-seeking groups in Canada and how to increase levels of trust, but also to conduct research where we can also understand the specific issues, right? The specific standpoint, the concerns that different groups of Canadians have, so that we can address that within community practices. So really by building partnerships within community. So that's the goal of sort of the focus that they're taking on this work. I'm part of a few different studies. So one that's specific to Nova Scotia that's being led by the Canadian Centre for Vaccinology here. And then with Dr. McDonald's study that's looking at equity-seeking groups in Canada. I don't have any data to report to you. I don't know if you do, Shannon, if you have any insights from your data set, but I can say that the work is occurring. It's crucial and important, especially if you look at the new list that Dr. Kellner talked about in terms of the prioritization of people from racialized communities for vaccine rollout that just occurred, I think, yesterday. So this is going to be key work, but it takes time and it needs to be centered on partnership, but it is happening. I don't know, Shannon, if you have anything to build on that.
Well, thanks, Gina. I'll mention that we have data actually we're presenting tomorrow. A presentation being hosted by the College and Association of Registered Nurses of Alberta. That actually shows that newcomer populations and Indigenous populations do have some of the higher levels of concern about vaccine uptake, more so than folks in other equity-seeking groups like visible minorities and people whose first language isn't English or French. And obviously there's some overlap there with the newcomer population, but newcomers and Indigenous populations certainly a lot of the challenges are around trust, quite legitimately due to historical experiences. But are there any of our other panel members who would like to comment on that topic before we return to Dr. Hu's slide?
Yeah, this is Raj. I'm happy to talk about some of the issues. So this kind of goes back to what I was saying around the kind of constellation of reasons why there are people who are hesitant. It's not a single reason. It's a very complex reason. And, in order to really kind of break this down, we really, as Jenna said, we really have to make sure that we are, responsibly and respectfully forming partnerships within these communities, and trying to really understand and then kind of understand their perspectives and then trying to accommodate, what what we want to achieve within the context of what they experience and live. And so we are currently working on a really interesting project with a group called Partners in Health in the United States. They are an international development organization that is now doing a lot of public health access work among vulnerable populations in the United States. And we're working in Montgomery, Alabama on this very specific issue because among urban populations, African-American populations, there is also a lot of hesitancy that specifically relates to things like, as you said, poor bad experiences with the healthcare system, lack of access, historical injustices. These are the same sort of very similar type of issues that many of the indigenous populations, have experienced here in Canada. And so I think, the way we're approaching it is by reaching out to community-based organizations, faith-based organizations, and really having them and the trusted leaders within these communities be the kind of bridge between those of us who are trying to increase vaccine confidence and the communities themselves. And that kind of engagement, it's a very, very sort of it's difficult engagement. It takes a long time. It's a lot of discussion and conversation, but it's very worthwhile. And I do think that, as we see these kinds of conversations grow in Canada, I actually do think there's an opportunity here that is even much larger than the vaccine, which is around building confidence in healthcare writ large. So, I do think it's really critical and important work, and I'm glad to see it's now become a real focus for the government of Canada.
Wonderful, thanks very much. Dr. Hu, are you ready, or should we?
Yeah, I'm just trying to answer the questions in the chat box, but
so I'm just going to read aloud a question in the chat box that is directed to you and relates to the information you're about to share, for folks that can't see the chat box. So it says, you mentioned healthcare aides being a group of individuals at the intersection between healthcare and the general public. Do you feel focusing on public health vaccine uptake in healthcare aides would lead to increased vaccine uptake in other important general population subgroups? So maybe you could talk about that at the same time as you're answering the previous question about vaccine hesitancy in different subgroups of healthcare workers.
Yeah. So anyways, on the slide, I'm just showing, this is this is how Vax presented it, but this is by worker type. People will get the vaccine right away, wait, no, not sure. I think that question, this is really good. I mean, every time we you want these interventions, so to speak, to be as targeted as possible, right? And when I say interventions, I mean, this includes, I think what the others are saying, I think building trust is probably the most important thing. And so, whether it's engaging community leaders, of course, putting in people's language that they need to speak, or things even a little marketing campaign, you want to be targeted. But for sure, I mean, I think that across groups, there's similarities in why people don't want to get vaccines, and there's differences in why people don't want to get vaccines. And so I think that every time, the stuff that we're doing in Montgomery, right, will inform the stuff that we do in Canada. It won't be the exact same, but I think that, there are things that can sort of cross over. It does link actually to one of the other questions in the box that Jim DeWald asked, but I'll let Raj answer that more fulsomely. But another reason why we would want to sort of look for healthcare, target healthcare aides right now is, I mean, they can get vaccine right now. Whereas, we're not going to tell people to rush the pharmacies for vaccine because it's not available. And so, I mean, there's so many reasons for that. I mean, when I think about other sort of racialized communities, that group will get vaccines sooner, but not quite yet. And so we have a month or a couple months to prepare. And I do think sort of the timing of our interventions is quite critical so as to not to make people annoyed. But I think one thing you can always do ahead of time is form partnerships. And frankly, when it comes to any vulnerable group, I never would recommend opening with get vaccinated, right? I would always say, what do you need? Right. So the bulk of all the work, and Calgary is super good at ethnocultural refugee outreach, is can we get you food, income, ISO support? you know, like around COVID itself rather than the vaccine. I mean, I think that like telling people they should get vaccine in a group that doesn't trust government is like not the best idea. But that was sort of a rambly answer. And I don't know, people have any questions about this little slide, just like let me know.
Great, thanks very much. I'm going to jump to a slightly different topic because I think it's a good question perhaps for Dr. Kellner. The slide that you showed with the newer vaccines, and actually, Gia, if you can unshare your slide, then we can see the other speakers. A question for Dr. Kellner. You showed your slide where there's some newer vaccines coming out with lower efficacy. And I've heard lots of questions from people about, so if that's the vaccine that's being offered when it's my turn, do I want to go ahead and get that vaccine? Should I be, you know, trying to get the one with the higher efficacy? Like, do you have any thoughts on how we're going to manage this balance between efficacy and availability?
Yeah, thanks, Shannon. That's really a pertinent question that is in a way more theoretical than real, given the limitations in what's actually available. But couple considerations. The first is, you know, what is a meaningful difference in efficacy, or when it's rolled out to the general public, in effectiveness, and that is to do with how well the vaccine is available, how well it's delivered, and how many people are actually getting it. The goal of vaccination, of course, is individual protection first and foremost from the vaccine, but in addition, then it's contributing to this concept of herd immunity, where if enough people get vaccinated over time, then it will help decrease the overall existence and transmission of the virus in the community. And so I think it's sort of easy to see if you look at the numbers and say, okay, on the, vaccine A is 95% effective versus vaccine B, which is 63% effective. If you had the choice today and both were sitting in front of you, I'd be hard pressed to find anybody who would not choose to take vaccine A. That's 95% effective. However, if, and this is the case in countries like the UK, the predominant vaccine that's available, the AstraZeneca, for example, which is more in the 60 to 70% effective, maybe higher in certain circumstances, is going to be the only one that's available for people. So that's the one they're getting. If it's an unknown time that you would have to wait to see when you might get a different vaccine, I would go ahead and get the vaccine as is now. So I'm kind of going on about this. It depends on what's available at the time. Over time, we'll find out if there's any value to receiving two different kinds of vaccines for people. I think, as has been mentioned by the other speakers, there'll be a time in Canada this year where I believe that we'll have more than enough vaccines that are good vaccines. And I think the final thing to say about it is, once you get to about 80% effective or more, I doubt that there's really a fundamental difference in terms of what it's going to do for you if you get a vaccine that looks like it's 80% effective on paper versus 95% effective on paper. That doesn't answer it all and it rambles a bit, but hopefully that's helpful.
No, I think that's great. It's certainly a question that's being asked. There's a really related question here in the chat, in the Q&A, that I'll read to the panel. In regards to the supply issues, what are the implications for the provinces opting to bypass national government procurement processes? Is this appropriate? Should it be allowed? Manitoba is the first province to approach Providence Therapeutics, and Alberta is also pursuing their own vaccine supplies because of vaccine delays. And Dr. Hu, I'm guessing by your response that you might like to take on this question.
I'm happy to hear others, actually. I mean, I have an answer to this, but if others have thoughts, like,
Well, John, I'll offer a perspective on this right now, which is to say that I think that at this time, this again, it reflects what you said earlier, which is that there'll come a time in Canada later this year where we'll have plenty of vaccine. And as you also said, the challenge is for us to prepare to deliver vaccine when we have almost unlimited supply. And our focus should be on this. I believe as a non-politician that the issue right now is more political than real. It is the normal course of events in normal times for provinces and territories to procure their own vaccine. But given the magnitude of the global public health emergency, it has so far been up to national governments to procure vaccine. And I think that even if you look at the challenges that Canada's had actually receiving vaccine, where we're at in terms of planning for and getting vaccine is the results of the federal government's work that was done many months ago. And you can criticize, I'm not defending it as being perfect, but you can criticize it as you want. But eventually, and coming forward, that's going to pay off in terms of vaccine supply. If somebody offers to buy vaccine today, they're going to go into the list of people waiting to receive vaccine, and it's hard for me to see how that's going to actually improve things unless you offer to pay dramatically more than price, and perhaps there's some room for that. What the government of Manitoba did was offer to buy a vaccine that is in phase 1 to clinical trial stage right now. I would, as a proud Albertan and Calgarian, I would love to see Providence Vaccines, a very small startup company, be successful. It would be amazing if their mRNA vaccine came to be useful. But Manitoba has really sort of hedged their bets because it said they'll only buy the vaccine if it's approved for use in Canada and if there's a sufficient supply. So there's really a pretty little risk for that province unless they have a fully developed approved vaccine to take. And this strikes me as more as politics than policy and trying to do the right thing.
Yeah, no, that's a really good answer. I'll just answer this, right? So look, like premiers have tried to buy directly, and like the pharma companies are like, screw you, right? Like it's kind of hilarious when they do that because they're not, like, it's really against the rules, so to speak. Two, I mean, again, I wasn't involved in signing the APA, so if anybody in the call was, it'd be great to hear your perspective. But I think Canada's done a pretty good job, actually. Like, we were always going to be in trouble, given the fact that, like, as soon as the US got organized, like, aka when Biden came into power, they're going to, like, give their vaccine to their own people, and same with the EU, right? And so, I mean, I think that I don't even know if, you know, if we paid 5x for vaccine right now, if we could, like, jump the queue as a country. I mean, if we could, I probably would recommend it, given the very high ROI of vaccination to, like, reopening. And totally agree with Jim, right? Like saying you're going to buy, like, something with a phase 1 trial is like sort of buying a lottery ticket. Like, and it is really political. The whole thing is quite cute, right? Because the premiers are blaming Trudeau. But it's like, it's kind of funny because, like, he's doing a pretty good job, and it's like you can't really do anything about this. Maybe ahead of, I mean, like Israel, people often cite as an example, right? So Israel did pay more, and Israel also promised essentially Pfizer that they could, like, actually evaluate the heck out of, like, their national rollout. And, you know, Israel, small, organized, like, good EMRs, one system, as opposed to, like, Canada's 10 plus 3, like, plus federal system. Like, it just, like, they can do that. But I think that, you know, like, I don't focus too much on federal procurement, like, only because, like, we can't influence it as much, but maybe we can. There's a company called Medicago based in Quebec. You know, I think they're going to prioritize Canada to entering phase 2-3, 52 million doses, so we can hope that they work, and that'd be good for us. But it does, I don't know, speak to, like, larger issues around sort of like the importance of domestic capacity in production. So I'll shut up now. But this is a really fun topic, I think.
Gina or Raj, do you have anything you want to add around the supply issue? Otherwise, we'll move to the next question. Oh, okay, so there's a couple of questions that are fairly linked together, coming back to the public communication issue. So one is directed towards you, Raj, specifically here. It says, given that public engagement is so important to developing effective communication strategies, what would you say are the best ways to do this? And you may have touched on this a little bit in your previous answers, but I'll read the other question, which is related, which is, the perspective seems to be that there's no downside to efforts to persuade people to take vaccines. But in fact, pushing too hard can create its own problems. For instance, Bill Gates promoting vaccines led to numerous conspiracy theories. How do we make sure we ride the line between promoting vaccine and not promoting conspiracy theories? So perhaps, Raj, if you're comfortable jumping in on either or both of those, and then maybe we'll, Gina, if you're, that seems in your ballpark around information and communication.
Sure. On the public engagement side, I think there are a wide variety of different tools that can be used. The first, of course, is just standard promotion. So creating not really in the public service announcements, because again, I feel like the kind of prescriptive public health messaging has not really worked beyond the kind of key population that Jenna actually showed in her data, which is people who are educated and who watch television news. They seem to be very in favor of vaccines, but people who, for example, follow social media and other types of trends seem to be more skeptical. So there, I do think there has to be kind of a multi-pronged approach. So the first thing is, having a, that's kind of why we started 19 to 0. So the first is having an information source that is sort of free of conflict in a way. That is that represents all sort of sectors and societies, that is sort of multi-sectoral. And so anywhere you are on the political spectrum, you can see yourself represented in a, if you believe in the private sector, they're part of it. If you believe in science and government institutions, they're part of it. If you could see yourself in that spectrum. So the source has to be something that can be trusted. And I do think, that's one of the reasons why we tried to create a multi-sectoral coalition with 19 to 0. Second is that in terms of specific communities, engagement with community leaders is really, really important. So we are, as I said, we're doing that in Montgomery. We're doing that all over actually Canada within the broad scope of 19 to 0. We have physicians that are talking to many different kinds of specific communities, whether it's vulnerable populations or healthcare workers, and giving different kinds of information to them that is true and real and that speaks to those communities. And the last bit is around, there's no downside to efforts to persuade people to take vaccines. And is there a concern about creating more conspiracy theories? I think, yes, there has to be a concerted effort to try to take on conspiracy theories, because there are actually bad actors out there who are trying to disseminate information in order to hurt people, in order to prevent people from getting information. And there are sort of there are strategies that can be used to combat that. But I do think in general, what you want to do is you want to give people correct, valid, legitimate, proven information, and you don't want to just do it in a fact-based way. You want to communicate to people the emotions behind it. People have lost jobs, people have lost loved ones, people are afraid for their lives, afraid for their family members. I do think drawing the emotional connections between what it means to be vaccinated and getting our country back, getting our families back, getting our engagement back, getting our jobs back. Those are the kinds of connections that speak to people, that are meaningful. And then within that context, you can present those kinds of fact-based information that people will then, I think, be more willing to take in and more readily absorb. So that's, you don't want to trick people. You don't want to, you're not trying to trick people into doing something that they shouldn't be doing, but you're trying to show them all the dimensions of it that can be very impactful in ways that they're, would be most receptive.
Great, thanks very much, Dr. Parsons-Lee.
Yeah, I completely agree with everything that was just said. I guess the one thing that I will also add is, so I agree that trust needs to be, at the core of all of our messaging. I think it's important that we don't discount things like social media. So even though I showed data that said, people aren't trusting social media, if you look at the data, underneath the numbers, a lot of what we see is that people really the back and forth that social media allows really resonates with people. So rather than just being fed information, the ability to communicate about information, to ask the questions that you have and get answers from people that that you trust, that you have confidence in, that feel like you, that resonates with you. So this ability, whether it's over social media or in other avenues, to have two-way communication, I think is crucial. And we saw that with our younger respondents. So within the 18 to 29-year-old age group, that was one of the things that came out, is that they feel like, in terms of what they're learning about COVID-19, they learned a lot of it over social media. Yes, a lot of the times it was based on information that was coming through public health, but then this idea to have discourse around it felt less fake and felt less like it was being fueled or kind of sent towards them with an agenda. And so I would say that that's sort of the essence of communication, back and forth communication, should be a core strategy in all of our vaccine sort of target interventions.
Great, thanks. Dr. Kellner, did you have anything to add there?
No, I don't have anything to add.
Okay. Building on that, there's a question here looking for some really pragmatic advice on go-to websites for lay people with friendly graphs, easily understood reasons we're seeking herd immunity, etc. So if the speakers have suggestions, but maybe what we could do at the end of the presentation is the same place that we post the recording, we could perhaps post a list of websites that people can link to. So I'll let the panel maybe comment on what sources they would suggest people go to. And the second part of this question is if Alberta were allowed to participate in the Canada COVID tracing app, would there be less fear of some sort of conspiracy? So any takers?
Maybe I'll jump in on I think both of those. So let's take the first one first, which is around do you think that it would be a good thing to like have different kinds of websites and information for the lay public? And I think the answer is, of course, absolutely. There's no downside to that. Are there any specific websites that I would recommend? I can't think of any offhand, but I can tell you that if you just Google, there are a million websites. The problem, of course, with the websites is that there's an information overload right now, and there's so many different rabbit holes you can kind of get go down that it's very difficult to kind of evaluate which are the right ones and which are the wrong ones in terms of health promotion, which is why I think maybe using social media to kind of give out the best facts is also optimal. Although I have to say, like for example, here in New York, the local New York City government, for example, does really, really great, very specific informational type approaches, and they have good resources. And I think probably local governments all over the country, both in Canada and the US, probably have those resources available to them. The second is around the track and trace app. It's interesting, obviously in Canada, it's been very politicized, in Alberta specifically versus Canada. It's interesting because regardless of whether or not, the efficacy of these apps actually is based on the uptake. So in other words, if the app can only actually work, if a very large number, around 60 to 70% of any given population actually uses the app. That's the only way there are going to be enough meaningful interactions among people that you're going to be able to see what community transmission looks like. And unfortunately, neither the Canadian app nor the Alberta app have really, while there's greater uptake of the Canada-wide app, it certainly hasn't met that threshold. And so, as far as I can see right now, You know, Singapore is a place where, you know, there has been some technological intervention that has worked, but largely across the world, I'm not sure that the technologies have really borne anything out in terms of efficacy against community transmission of the virus.
Thank you. Anybody else want to add to that response? No. Okay. Question for Dr. Kellner around vaccine safety. We know that vaccine safety and questions about vaccine safety are a huge driver of people's questions about the vaccine and their intentions to vaccinate. And we hear a lot of people wondering, so the clinical trials have been done, but do we know if there's any long-term effects of the vaccine? And what about really rare adverse events? So I wonder maybe if you could speak a bit about any mechanisms that are in place across Canada for tracking adverse events long-term and rare adverse events.
Sure, thanks very much. So first about what do we know already and when would things occur? It is the case that vaccine adverse effects, they may linger if there's some serious effect that can linger for a while, but the likelihood that effects that are known that can occur related to the vaccines will occur is that they'll occur within the first 6 weeks after immunization. It is not the case that vaccine adverse effects will show themselves for the first time months or years later. They'll show up in those first weeks. And so we're very quickly accumulating information from vaccine implementation surveillance that's been done, including in Canada. The second is about very rare side effects. So this is an important point because the clinical trials, if we look at the 2 mRNA vaccines, there's about 60,000 people that took part in the 2 phase 3 mRNA vaccine trials. So certainly with that many people who took part in the trials, there's enough information to tell you about common, 1 in 10, uncommon, 1 in 100, rare, 1 in 1,000 adverse effects. The very rare, 1 in 10,000 or less, those are the ones that you're not going to see so much, even if you have 60,000 people in a vaccine clinical trial. And so the good example of this was anaphylaxis. It was only after millions of doses of this had been delivered that we've started to see about what the rate of anaphylaxis is, and it turns out it's reassuringly low. For other kinds of very rare side effects, there is in place in Canada, in Alberta, in Canada, 2 systems to look to. One is the existing passive reporting system of for APHES, adverse events following immunizations. And this is a public health run program that's in place for all vaccines. And in Alberta, there's been updated legislation making it a requirement to report APHES for healthcare practitioners. And there have been numerous reports of various different APHES, which can be anything that can occur after a vaccine. In addition, there's an active program that is supported by Public Health Agency of Canada called Canvas COVID. And Canvas COVID, which is a study that I'm part of in Alberta, is a program that sort of cut its teeth doing vaccine safety surveillance for influenza vaccines that are new every year. It's pivoted towards doing COVID vaccines, and the aim is to enroll up to 50,000 Albertans per vaccine to participate in this, where they would, at the time they get immunized, those who on the call who may have been immunized, you may have seen either a sign at the clinic you went to with a QR code, or it's in the sign up for the vaccine that you can participate in this. And in that, you do a survey 1 week after the first vaccine, 1 week after the second vaccine, and after 6 weeks. So the combination of this passive system and an active system like Canvas COVID, the goal is to do a really comprehensive job in Canada of looking for safety signals.
Great, thanks very much. We have about 5 minutes left if anybody online has additional questions, but maybe I'll pose another question to the group. I have a particular interest in populations that have trouble accessing healthcare services, underserved populations. And when we start moving into the phase of vaccine rollout, where we're sort of putting the call out to people to identify themselves as being eligible rather than our current stage where we're pretty much tapping people on the shoulder and saying it's your turn. How do you think we can reach populations where maybe language is an issue, use of technology is an issue, to ensure that they know it's their turn and how to make an appointment? Any of the panelists willing to tackle that?
Maybe maybe I'll take this because I'm pretty, like, at least in Alberta and Ontario, pretty involved with like the actual logistics of all this. And so a few key points. Number one, I think that operationally, it is very difficult for any provincial government to do any detailed planning 1 month in advance, like more than a month in advance, which is just sort of like what's happened to date. But we should try to do better. Number two, I mean, I think that, as you'll see some of the prioritizations, like there's a few things, right? So by and by, it's been like healthcare workers and like old people and certain settings, long-term cares. When we have to find like, certain vulnerable populations that aren't we don't necessarily have a really good plan for that yet in Alberta. I mean, we're trying to work on it. But for even like if we're trying to find somebody with like who works in a meat plant, I mean, that's sort of easier in a way if we just do on-site like immunization. But if we're talking about, like anybody who is from a certain population group, I mean, let's just say the operational bits aren't totally well thought out. But in terms of like how best to approach this, I mean, it goes back to everything that's been said before, right? Like one, you really need like the trust of that community. And to do that, I think Gina said this, but you want to work with groups that have been working with the community for a long time. Two, like, I think to build that trust is quite imperative actually to support communities with what they actually need. And so the bulk of our work with the ethnocultural groups in Alberta, Ontario, which is across the country right now, is actually centered primarily around isolation support, food, income, all of that stuff, right? Three, I think that it's like a sine qua non, you're gonna like translate this stuff for sure, like that's pretty obvious. One thing we're trying to get occurring in Alberta, Ontario, and around is actually just like immunization clinics that are like run by community organizations that are like located close to where people actually live, right? So you want to reduce barriers to like as much as possible. And so I think that I'm sort of reasonably confident that we'll get there. I mean, it's just like, in a way, I think this is one of the biggest logistical challenges ever. This whole vaccine thing, like in general. But on the other hand, I mean, you actually have a plethora of groups that know these populations working for a long time. Two, if we really do engage all society, and when I say that, like, I mean, like we are trying to work with every organization, period. Then there's actually quite a lot of slack capacity floating around the system. And so I'll stop, but like it's the last thing, yeah, no, I'll just stop. Really important question, Shannon, completely agree.
Any last thoughts on that from anybody else on the panel?
One of the things they're doing here in the U.S. is just, they're having the same supply issues, obviously, that they're having in Canada, but they're trying to think about ways to get the vaccines to where the people are, because, one of the key issues around vulnerable populations is health access. They just don't have the ability to access, they don't have the right number. So they're engaging private sector, they're engaging pharmacies, for example, and other types of private sector practices that may be very prevalent in communities to be able to help drive vaccines out into those communities. That's one example. But trying to make sure that everybody can access it is going to be a really, really key part of the strategy to engage these types of populations that you mentioned, Shannon.
Great, thanks. Yeah, I'm always very mindful of the fact that a lot of the discourse out there is about vaccine hesitancy, when in fact there may be people who have every intention of wanting to get vaccinated and just don't know how to access the service. So I think we need to remain mindful of that.
Yeah, I mean, just on that point, last thing I'll say is like, if you think about like how easy it is to access the healthcare system in Canada, it's really hard, right? Like in general, right? And so like whether it's like, I mean, I think like HealthLink's done a great job of scaling up like 10x in like 1 month, but like the way we book appointments, they would advertise appointments. Like, I think that there's so like that part is so important. And I think like we probably should, I view this as an opportunity to actually improve sort of like the patient centeredness of healthcare. Like I think we're pretty terrible at that, frankly, in Canada. The US often is better. There's a lot of problems in the US, but I think that like we can certainly make strides, and we should, because like those the convenience, as you would say, like really does impact people's uptake, even if they want it. Like it's annoying to get, waiting on a call line for 3 hours, right? Like.
Okay. Any final comments from any of the other panelists before we wrap up for the morning? Okay, well, thank you everybody for joining us this morning. I think we've had a great conversation that spanned across a lot of the topics that we're facing as we roll out the vaccines and new vaccines coming. My thanks to the audience for joining us today and contributing such insightful questions, and the panelists for sharing their time and expertise. I do hope that we'll be able to post some key links on the website for the O'Brien Institute that people can use to access information, so that we can do a bit of that curating of what is a good source versus, as Raj said, going down the rabbit hole of all the different sources that are out there. So thank you, everybody. I wish you all good health in the days ahead.